Good morning, everyone. And today we are going to talk about nephritic syndrome. Um, as you know, yesterday, in my one of the lecture, which is like parenchymal kidney diseases, in which I explained both the nephritic as well as the nephrotic syndrome, and with the mnemonic. So we know the clinical features of nephritic syndrome already. Like anyone who have a nephritic syndrome, they present with proteinuria, which is not in the nephrotic range, or you can say which is less than 3.5 gram per day, as well as hematuria, which could be microscopic or macroscopic. They present with azotemia, which means like there will be increased creatinine and urea. The RBCs, when we are going to send their blood to the labs, we will found like will be RBC cast cells. Then they can present from any range of, you can say, symptoms like oliguria. Of course they will be having hypertension due to salt and water retention. Their eyes and they have edema, their eyes become puffy, and they have smoky urine. And we all also talk about what can be the causes of nephritic syndrome yesterday with examples. So today, like, we are going to discuss few of the causes, like conditions which can result into nephritic syndrome. Again, I would like to start my story with um, uh, the first step. Whenever we see these clinical signs is like we go for the renal biopsy, and on the renal biopsy we come to know, okay, what is the type of nephritic or nephrotic syndrome it is. So first of all, what we are going to discuss today is IgA, IgA nephropathy. Okay, so IgA or immunoglobulin A nephropathy is the commonest type of glomerulonephritis which can present, especially in high income countries, or you can say the developed countries. This is a very, very common type of nephropathy which is present. So now most of the people who have IgA nephropathy, how they present is like they remain asymptomatic. Okay. Uh, Asymptomatic means like many of the times you can say they have non-visible, or you can say microscopic hematuria, which cannot be appreciated. Okay. Or sometimes they have some episodes of uh, macroscopic or visible hematuria. Okay. So this is like how, what is the presentation? It goes like this way. Now one of the things that IgA nephropathy, it results, okay, after infection. Okay, most of the time IgA nephropathy, it results after infection. You can say 12 to 72 hours after infection. This condition started its symptoms. IgA nephropathy is also called as Berger's disease. Okay, this is the other name, Berger's disease. So as you know, what is IgA is? IgA is these are the immunoglobulins. So simply, it's glomerulonephritis. So there is inflammation in the kidney going on. So you can say like IgA nephropathy is the most common glomerulonephritis, okay? And what happens in this one is basically the IgA antibodies, they get deposited on the glomerulus, right? By the way, one more condition which we are going to discuss after this, and we had already discussed in pediatrics. If you remember, I told you about a condition called as Henoch-Schonlein purpura, HSP. HSP is also related to IgA, okay, because in HSP, there is vasculitis which is caused by IgA, okay. So many people consider these two conditions, they are close together, because this one is the IgAs are damaging the kidneys, and that one the IgAs are damaging the systemic vessels, right? So that's why they say like they associate these things closely, okay. So as I was telling you that most of the what we found in these patients is like before the onset of symptoms you will find a history of infection, okay, and most commonly upper respiratory tract infection. So what we found in these patients when they have this hematuria, uh, you can say you will found um, 12 to 72 hours before a history of infection, mostly upper respiratory tract infection, okay. So this condition occurs 12 to 72 hours after getting a upper respiratory tract infection, okay. Remember one more condition which gives hematuria and that occurs after infection, that is post-streptococcal glomerulonephritis, but that one occurs after a long time, not after within 72 hours, okay. So you can say like once if someone have upper respiratory tract infection and he have hematuria within 1 or 2 or 3 days maximum, most more chances it is IgA nephropathy. If like it is after that 7 days or 10 days, post-streptococcal glomerulonephritis, okay. Again guys, I am not going to talk about the sign and symptoms again because we have already discussed how a nephritic patients present with, right? So we are not going to talk about that thing again. So of course, like they present with the same nephritic symptoms, proteinuria, hematuria, and all these things. But up to 50% of the patients times it results in renal failure. Okay, so many people who get renal transplant, they have like the history of this thing. Okay, the prognosis is bad in males when their BP is high, their creatinine is high, they have like heavy proteinuria. So how to diagnose these patients? Diagnosis is simply done by renal biopsy. Okay, and basically what we found is IgA deposition in the mesangium. What we found is IgA deposition in the mesangium. I can show you one more photograph. See this one, IgA nephropathy. See, they found and what they can do is like they check, they see in the mesangium they found like there is IgA deposition. Okay, and the treatment remains simple, guys. Again, the same story, ACE or ARBs for hypertension. Plus, of course, they reduce proteinuria. And And then we can give them corticosteroids. Okay, we can give them corticosteroids if they have proteinuria and persistent proteinuria. Okay, so first of all, we give them AS inhibitors and ARB inhibitors. What they do, like they for treating hypertension, plus these drugs, they reduce proteinuria. This is a very good function of these drugs. If after giving these drugs they still have proteinuria, put them on corticosteroids. Okay, so this is about like IgA nephropathy. One other cause of what you can say glomerulonephritis is Henoch-Schonlein purpura. So what happens, like in HSP or Schonlein purpura, or HSP, it is also called as HSP. It is the same condition, like there is IgA vasculitis, right? So when there is IgA vasculitis, what will happen, like this IgAs are going to damage the skin, the vessels which are on the superficial vessels of the skin, and once that will damage, like there will be leaky, like they will become leaky, the blood will leak out, and the patient will present with purpura or petechias. If you remember, I showed you this thing before in pediatrics as well, especially on the lower limbs. They have this petechial rash on the lower limb, especially on the external surface. And as there is IgA vasculitis plus the IgA, plus what will happen if the IgA are circulating in the blood, so what will happen, IgA will simply go and deposit in kidney as well and cause the same damage, or can result in IgA nephropathy, right? So they present with this purpuric rash. Purpuric rash will be there in these patients. And also these IgAs can deposit in skin, in joints, in gut. So whenever this IgA will deposit in the joint, so polyarthritis. When this IgA will deposit into the gut, so abdominal pain can be there. Even GIT bleeding can be there. Okay. And of course, it will result into nephritis or glomerulonephritis, right? So how we diagnose them? We can go for blood investigations, and we can do a blood. Okay, most of the time, the diagnosis is clinical. We see this one, rash and all this stuff of, okay, done, it is HSP. But if you want to confirm, you can take a skin biopsy even, and what you will find in the skin biopsy, you will find IgA depositions and also complement 3 C3. Okay, or if you will do a renal biopsy, for example, what you will find, again the same thing, you will find IgA nephropathy, right? So this is the thing. And again, the only thing we can do is we can give a steroid trial. Okay, especially the steroids are given when there is gut involvement, we give them steroids. Okay, so this is like how we go and treat this condition. One of the cause of glomerulonephritis is post-streptococcal glomerulonephritis. This thing also, we had discussed in a great detail in pediatrics. Again, okay, take it as a revision, and like we can talk about this thing as well. Now what happens, what happens in these patients is they have again the same, any infection. It could be a skin infection, it could be a throat infection or sore throat, right? Anything can be occurred by streptococcals. Okay, and whenever it is there, you can say when it occurs after skin infection, it takes 3 to 6 weeks to develop. So in skin infection, it takes 3 to 6 weeks to develop. Okay, but whenever it is after throat infection, it takes less time. You can say approximately 2 weeks. Okay, approximately 2 weeks it takes to develop this thing. So what happens, like, you can see this one, a very simple diagram to show you that this is someone have streptococcal infection. Okay, these are the weeks they're showing you, and what happens, like, see, C3 levels are going down and ASO titers will start increasing. And this is what we check, like ASO titers in these patients, and see, like, after that, there will be edema, hypertension, hematuria, or simply the features of glomerulonephritis, right? Nothing special. We have discussed this thing many times over and over again. So what's happened basically is that the streptococcal antigens get deposited in the glomerulus. Okay, so of course, like, they damage. Okay, so what happens, like, there is immune complex formation, and once this immune complex formation is there, it causes inflammation. Okay, so of course, like, due to this inflammation, what happens, like, post-streptococcal glomerulonephritis occurs, and the features remain same, guys. It is a nephritic syndrome. So clinical features, again, you can remember this, you can remember by mnemonic, or you can remember anyways, like this. So how we diagnose them? Of course, like, we will get clinical history of infection, very important, right? So first of all, you will find the clinical history of infection. You can check their anti-streptolysin, ASOT will be raised. Okay, so it will be raised, of course. Okay, anti-DNAs will be raised. So it will, like, all point towards the same, and complement levels will be less. Okay, so C3 will be decreased in these patients. Okay, so of course, like, most of the time it is clinical diagnosis. It is like hematuria in these patients after getting this sore throat. Of course, like, what they do, like, they make a diagnosis of what you can say, post-streptococcal glomerulonephritis. So you can see this one, a very helpful diagram, by the way. Post-streptococcal glomerulonephritis is also called as acute proliferative acute post-infectious. Most of the time occurs in children, mostly in winter and spring. Etiology: glomerular trapping of circulating immune complexes. Group A, beta hemolytic streptococci, GABHS. Clinicals will be nephritic syndrome features, and these are the labs we can do. Decrease serum complement, smoky urine. Okay, there will be evidence of streptococcal infection. What is the pathology? There is enlarged hypercellular glomeruli. You can see over here, with endothelial and mesangial cell proliferation. Neutrophils will be found, IgA, C3 in very coarsely granular pattern along GBM. Discrete subepithelial hump-like deposits will be there. So you can see over there. Okay, they're showing you how they look like. Okay, so this is how they look like, and this is how we diagnose these patients. So simply, what should be done in these patients? Once the diagnosis is made, then we go for treatment, and treatment is mostly supportive. Okay, treatment is supportive. Of course, why? You cannot give anything. Of course, if there is still infection, you can give antibiotics. Okay, Otherwise, the treatment is simply supportive. We keep on checking them, what's going on with them. One of the condition is also called as anti-glomerular basement membrane disease, anti-GBM disease. Yesterday I showed you, RPGN type 1, Goodpasture syndrome, when the lungs are also involved. So previously it was called as Goodpasture syndrome or Goodpasture disease. So what happens is like there is autoantibodies to type 4 collagen which is present in glomerular as well as the alveolar basement membrane. Okay. So what happens in this condition? Autoantibodies are formed when against, you can say, type 4 collagen. So one of the bad thing is this, that this type 4 collagen is present in the glomerular membrane, basement membrane, as well as the alveolar basement membrane. So what will happen in these patients? Like there will be nephritic features, clinical features, but now the alveoli are also damaged. So simply there can be pulmonary hemorrhage. Okay, so this is a very important thing. So when there is pulmonary hemorrhage, of course, they present with hemoptysis, they present with shortness of breath and all these things, right? So this is the thing, which we see. And when we are going to do a biopsy in these patients, what we will found as like anti-GBM antibodies. Okay, antibodies will be there in circulation, as well as deposited in the kidney. Okay, so now you know how they look like. I will show you. This is the immunofluorescence test, which is done for IgA are deposited. So this is the immunofluorescence which they have done. Now guys, remember, now the condition is caused by anti-GBM antibodies which are circulating in the blood. So we can do plasma exchange therapy, of course, like to give them a different plasma which is like free of this thing. We can give them corticosteroids, okay, as well as we can give them cyclophosphamide, of course, like to like decrease their immunity, or immunosuppressions should be given, of course, like in these cases. So you can see over here, I can show you this thing here. This is the renal biopsy finding in anti-GBM glomerulonephritis. What they are showing you, like this is the normal glomerulus, and this is like the anti-GBM crescenteric glomerulonephritis. Okay, and this is the immunofluorescence. What they are doing, and see, same pattern. The bright green color shows the location of anti-GBM antibodies. Okay, all over the glomerular basement membrane. You can see these antibodies. So this is how they present. Okay, these patients. So the last condition which we are going to study is like rapidly progressive glomerulonephritis, or it is also called as RPGN, rapidly progressive glomerulonephritis. Okay, so in other words, if you know, the crescenteric formation, okay, I will show you the crescenteric formation in this one, for example. When we do the immunofluorescence, because of the deposition of this circulating antibodies, there is this crescenteric formation, and that's like how RPGN looks like. So as the name shows, it is like rapidly progressive glomerulonephritis. So remember, guys, RPGN is one of the aggressive type of glomerulonephritis. Okay, this one is one of the aggressive type of glomerulonephritis. So very aggressive condition. So it deteriorates very quickly. So it's an aggressive, you can say, glomerulonephritis. So it progressed to, you can say, renal failure within days or weeks, you can say. Okay, very quickly it's progressed. And simply like there is circulating antibodies, okay, which basically can damage the kidneys, it can deposit in the kidneys. So the causes of this condition could be many. For example, it can occur in small vessels, vasculitis, like microscopic angiitis, okay, Schwartz's disease and all these ones, Wegener's granulomatosis, things like this, or for example, lupus nephritis, okay, like which occurs in SLE. So simply like there is circulating antibodies which keep on depositing into the kidney, and it will lead to crescent formation. Okay, so of course, like we on renal biopsy, we see crescent formation on renal biopsy. Okay, this is the hallmark of this condition. Like on renal biopsy, when we see crescent formation, so of course, like it is RPGN, and of course, like that's why it is also called as, like, one of the other name is crescenteric glomerulonephritis. So again, like it is immune related. So we give them corticosteroids. Okay, we give them cyclophosphamide. Uh, Phosphomide can be given, which is like, of course, like to decrease the immunity, or if the condition is very rapidly progressive, so we can go for plasma exchange therapy. Okay, so of course, like to uh, decrease the circulating antibodies in the blood. Okay, so of course, like to make this condition better. So rapidly progressive glomerulonephritis, of course, like within days to weeks, uh, it can progress to renal failure. And remember, guys, this one is mostly a clinical diagnosis where the patient condition is becoming so bad. Okay. Now, the very important thing to tell you guys, all the things which we study, FSGS, MCGN, IgA nephropathy, Henoch-Schonlein, purpura, whatever we study, all of them they can progress to rapidly progressive glomerulonephritis. All of these conditions can lead to rapidly progressive glomerulonephritis except minimal change disease. Remember, I told you minimal change disease, or like in causes IK, we can add this thing. All the glomerulonephritis can present as RPGN, or rapidly progressive glomerulonephritis, except one condition, except minimal change disease, right? So other than minimal change disease, every condition can present as RPGN. So whenever like anyone have, for example, you have a patient who have focal segmental glomerulosclerosis, or you have a patient who have IgA nephropathy, if his condition is deteriorating too fast, we call it as rapidly progressive glomerulonephritis, right? Even anti-GBM disease, even someone who have Wegener's granulomatosis. So, see, clinically, any patient who have glomerulonephritis and his condition is deteriorating too fast, we say that the patient have rapidly progressive glomerulonephritis. But when we send a biopsy to the lab and we get a result that the patient have crescenteric glomerulonephritis, like crescent formation, then we can name it as crescenteric glomerulonephritis. Okay, so this is what is the difference, and that's why Um, they classify RPGN, or uh, rapidly progressive glomerulonephritis, on four types. There is type 1, which is also called as anti-GBM mediated. Okay, 15% of the time it is the cause. Then there is type 2, which is also caused by immune complex, which is caused by immune complex mediated, okay, which is immune complex mediated, 24% of the time. There's type 3, which is basically non-immune mediated. I show you yesterday one, if you remember, one table in which like all of them they are written. This is the most common one. Okay, most common type is this one. And there is type 4, which is basically double double antibody positive. Okay, so if you want, I will repeat again. All the glomerulonephritis which we study, whenever they are progressing too fast, we say that the patient have rapidly progressive glomerulonephritis. When we send it for pathology and we get back crescent formation, we say that the patient have crescentile glomerulonephritis. Both of them, they are the same thing. So what should be the treatment of this thing? Of course, like if you found any underlying cause, treat that. Otherwise, give like corticosteroids, cyclophosphamide or immunosuppressants, give cytotoxic agents. Plasma exchange therapy can be done. And of course, like many of the people, they respond to this therapy, but all those don't respond, many end up in end stage renal disease or renal failure. Then of course we have to go for transplantation. So I hope you guys understand these things, and my next lecture will be about secondary causes of glomerular diseases. Oh no, sorry. My next lecture will be about acute renal failure, because we had done. I already talk about like what are the secondary causes of glomerular diseases, like in last lecture. Same thing, amyloidosis can cause, systemic lupus erythematosus can cause, Henoch-Schonlein purpura can cause, Wegener's granulomatosis can cause, hepatitis B, C can cause, HIV can cause, syphilis can cause. So of course, like these are the systemic causes. So okay, so thank you so much, guys. See you in the next lecture.